what I've tried to do today is basically, obviously there's many different aspects of this pandemic that we can talk about, but I've really tried to focus on some of the questions that were brought up to me and look at more some of the basics with regards to virology and what's going on with this virus, and some of the manifestations, treatment, what we can expect, testing. So this is my agenda. We're going to really review some of the basics. What is a virus? What are coronaviruses? And why is this different than what we've seen previously? We'll do a little update on global and regional numbers, not terribly helpful because they change so much, but just to kind of give us a ballpark idea, and then talk about why is this impacting certain categories of people more than others. There's been a lot of question about reinfection and immunity, and of course we don't have all those answers yet, so I'll just try to give you basically what we think, talk about testing, treatments, and what is coming. I do kind of straddle the hospital inpatient as well as the outpatient, so my perspective is a little bit of both, but we'll just get going here. So what is a virus? Well, this is actually, there's a question as to whether viruses are really alive. They are kind of on the border of what is a living organism because they are made up of certain kinds of basic particles, either RNA or DNA nucleic acids, which is the genetic code, proteins, and then lipids. And then those are all assembled. They're very, very simple organisms assembled into a particle called a virion, but they can't do anything without getting inside a host cell, and then they more or less hijack the machinery of the host cell to make more virions replicate. So in terms of reproduction, they only can do it by basically utilizing a host cell. They're much smaller than bacteria. They weren't even recognized until about 1892, when through filtration processes, it was generally come to know that something else is causing people to be sick that's very, very small. And it wasn't until the electron microscope was developed in 1931 they could actually see it. Coronaviruses are pretty simple. They are RNA viruses. They have basically, once they get inside the host cell, they kind of similar to HIV, they attach through a receptor, they get into a host cell, and then right there in the cytoplasm of the cell, they use the host machinery to replicate. HIV is different because, as we all know, it's a retrovirus, meaning that it starts out as an RNA virus, but once inside the cell, it actually makes a DNA copy. That DNA copy then enters the host cell's genome or nucleus, kind of slices itself or integrates itself into the host DNA, and that's where it can really move on to be a chronic infection. Most of the time, those cells go on to continue to make, activate different aspects of the cell to eventually produce new virions, but sometimes those cells go into a resting state. So that's not something that happens with coronavirus. So they're really, HIV is actually a much more complicated virus than the coronaviruses. So coronaviruses, we've known about them for a while. There are actually two different human genera or groups of coronaviruses, 7 that are known, and 4 of those, so 2 of the alpha and 2 of the beta, actually just cause kind of common cold symptoms. They can cause very serious disease, and I've had patients on ventilators, et cetera, even die of the old coronavirus infection, but always somebody with immune problems or, advanced cancer chemotherapy, et cetera. And then we had SARS and MERS hit, and of course now our SARS-2 virus. So those are the 7 human coronaviruses. SARS-1, just a brief run through on that one. That was first originated again in China in 2003. And the outbreak was actually actually fairly short. It did cause over 8,000 cases and 774 deaths. And the case fatality rate, that is how many people who are diagnosed die. And that's not really an understanding of how many people have the disease. We really don't know the extent of SARS-1 because general testing wasn't done. So what we have is a case fatality rate. So only those people who were identified as having SARS, how many of those died? And that was pretty high at 9.6%. Again, thought to have originated as a bat virus, and children were not severely affected. And that epidemic actually, or outbreak really, was able to be contained through testing and isolation. Some people think that the SARS virus mutated to a more a less virulent form, but that's not really the case. This was we had the capacity, or at least they did, to identify and isolate, and then the outbreak was contained. MERS, Middle Eastern Respiratory Syndrome virus, started in the Middle East, and confirmed cases again, only the people that were actually tested were about 2,500, but the number of people who were felt to be infected was actually higher. There were some scattered cases, but usually directly connected to a visitor from the Arabian Peninsula. Camels seemed to be the host, and that actually had a very high case fatality rate. Why did that one die out? Well, in the next couple of slides, you'll see this was not that contagious. So it was actually going to die out just because it's not that contagious. SARS-2, here we go. We do now think that it started with bats, 96% homology with a bat coronavirus. Again, felt to be due to the mixing of live animals. And we do feel it's transmittable by aerosols, fomites, and fecal oral. So that's really important for our patients to know that it has definitely been identified in stool, and we feel that that is a mechanism for transmission. Okay, so there are actually 8 strains, and this is a color just a color diagram of where these strains are. And the strains are very closely related to each other. At this point, we don't think one is particularly worse than the other. For example, the strain in North America actually did originate, all these strains originated in Wuhan. And there was some mutation, but that mutation does not seem to be dramatic or confer a higher virulence or to be a problem in terms of vaccine development at this point. So why is this so tremendously different than all the other viruses? Well, just to clarify, the SARS-CoV-2 is the name of the actual virus. COVID-19 is the disease you get from the virus. So we have so many different things going back and forth, but that's the information. Well, nobody's immune, obviously. So it's hitting everybody at the same time, and it's hitting all ages at the same time. So, you know, we know for a fact that certain viral illnesses are much better tolerated by children than adults. For example, chickenpox. It is a pretty innocuous disease if you get it as a child, but once you start to be an adult, you know, before we had the vaccine and all of that, you know, I was seeing people who were dying in adulthood from chickenpox, that they, up to 50% mortality. So I'm just saying that some viruses are really well tolerated by kids, but when they hit the adult population can be much more severe. And that is one of the things that we're seeing. Everybody's getting hit at the same time. The other thing is what I alluded to earlier, where we talk about the R0 number. That tells us how many people are infected by one sick person. So if the R0 is 1, the infection will die out on its own over time. So the R0 for H1N1, which we recently went through, is actually above 1. It's 1.5, but we had other mechanisms to help get rid of that. We had vaccines, we had treatment. Seasonal flu, again, similar, 1.3. Measles, very high, 12 to 18 individuals infected by 1. MERS, actually lower than 1, so probably why it died out, even though the case fatality was so high. And then finally, for this virus, we're thinking it's between 2 and 3. So on the high side, actually. And the other big problem is that we clearly are seeing asymptomatic transmission. It is now felt that with 48 hours before you develop any symptoms, you can actually transmit the virus. So, and then there's some people who remain asymptomatic at all times. Just a quick look at prior pandemics and what happened. Most of them were viral. Bubonic plague was actually a bacteria and killed 30% of Europeans. And you can see some of the statistics there. I don't want to waste too much time. We all know about AIDS, and that has had a huge impact, but it has been spread over decades. So the impact in terms of death numbers has not really translated to what we're seeing right now. But clearly very, very, very impactful. In terms of mortality numbers, the first SARS mortality rate, as I mentioned, 9.6%, MERS 34.4%. What about this one? WHO came out with an estimate in early March of 3.4%, but we really need a better denominator. So the mortality is how many people who have the disease will die of the disease. And that's where the denominator, if it increases, the mortality will go down. Looking at flu, seasonal flu, only 0.1%. The H1N1 from 100 years ago, 2%. Bird flu, very high mortality. That's the next one we need to worry about, but hopefully we'll not see that in our lifetime. H1N1, actually very low mortality. And then we also have the other bird flu, the H7N9, where the mortality rate was also high. So as of yesterday, these were our numbers for COVID-19 infection, and you can see them right there. Illinois is somewhere around 7,000 cases, and deaths, I'm sure, are higher today. And mortality is basically the, based on the cases that we have, not on all cases in the community, just what we have in terms of positive test reports sent to IDPH. COVID-19 presents in sort of a flu-like illness. You're all familiar with that. Incubation period, I've been asked many times about this. Most people will have symptoms between day 2 and day 11, even though we know that the full incubation period can go out to 14 days. Median, meaning half of all people who get symptoms will have symptoms by day 5. Fever can be high grade. I've seen 103 for a couple days, but in general, we see persistent low grade fevers that just keep going on and on. Fatigue is a part of this, very common, very severe at times. Cough, but usually not, bringing up phlegm, and then shortness of breath. Some people have a GI presentation where they have a profound diarrhea and loss of appetite. Most of those people then do go on to get the body aches, fevers, some of the other symptoms, but not necessarily the full respiratory syndrome. What we've seen in the States that was not described in China, but seems to be very common, almost 30%, is loss of sense of smell or taste. A few people can show up with what looks like a viral conjunctivitis. labs, what we really like to look at is the absolute lymphocyte count, which is low. So, we're all used to looking at the absolute CD4 count. CD4s are one type of lymphocyte, but if you look at the actual absolute lymphocyte count, if it's under 0.8, that's a bad sign. People generally have elevated liver tests, but don't usually go on to have liver failure or anything like that. And then other things we follow are markers of inflammation, stuff like C-reactive protein, ferritin, things like that. On chest x-ray, they can be normal, but a lot of people will have what we call ground glass, which is kind of a diffuse fuzzy picture, or patchy infiltrates, meaning like they're little patches here and there. So in terms of what happens, okay, so the majority of people will have mild disease, and this is what I think we have to keep reassuring ourselves and our patients. The majority of people will have mild disease. It doesn't mean they won't feel sick, and they will feel sick sometimes for a week or two, but they don't go on to progress to shortness of breath and require oxygen and then hospitalization. About 20% will require some type of hospital stay. Out of those, 5% go on to have critical disease, meaning that they are up for prolonged, ventilator support and blood pressure support, et cetera, et cetera. Others will require ventilator support, but not go through the more advanced stage. And, what happens in that advanced stage? Well, sometimes the blood pressure drops, sometimes the other organs start to go, but that's not what a lot of people are seeing. What we're seeing are really more two groups of people, one that are having this ARDS, which is just kind of leaky lungs, and then something called cytokine storm, which is a little bit later, meaning that they get kind of an overreaction of the body to the virus. I did want to mention that a lot of patients, even the outpatients, will have a two-phase illness. That doesn't mean they're going to go on to die. It is first a very mild illness, and then people get better and they think they're out of the woods, and then a second phase will come where they start to have fever again, or they start to cough, or they feel more fatigued. And again, that does not necessarily mean they're going to progress further, but that is the time we need to be more attentive to symptoms, and then some of those will go on to have pneumonia and heart problems. So the severe disease, who's at risk? And you've all heard this. And there does appear to be a specific issue going on with people who have high blood pressure and heart disease. So I would say that's really definitely a problem. And diabetes, people who have underlying lung problems, cancer chemotherapy. And in fact, the oncologists have actually stopped giving chemotherapy for the most part, because the mortality if you get chemo and you have COVID is really quite high. Or if you're on other immunosuppressives, high dose steroids, our patients with asthma in the community, we're really trying to avoid giving them a course of high dose steroids at this point, because that does seem to really put them at higher risk. And then age, which unfortunately I'm in. So starting at age 60, the mortality increases significantly by decade and really gets significantly higher over 80. And of course, many of these people have the conditions that we talked above earlier. So what about people living with HIV? Are they at higher risk? So this is a very interesting question. I can tell you that there's a lot of buzz in the ID community that we are not seeing this group of patients coming in with severe disease unless they have these other problems that I mentioned: hypertension, diabetes, chronic lung disease. So I would say at this point that HIV by itself does not appear to be an additional risk factor. I will not comment on whether there's any protective effect or if the medicines are protective. That is an area of tremendous controversy, and I certainly wouldn't get into that with any patients that ask. Basically, no one knows. So what's going on here? The virus uses this ACE2 receptor to get into the cell. It's found on the lining of the nose and throat, but it's also there in lung cells, heart cells, blood vessel cells. And, you know, the disease is more mild if it stays in the nose and throat, but then if it travels through the body and can get to the heart or the blood vessels, or if it gets into the lungs, that's when we start to see worse disease. And as I mentioned, the two bigger problems that happen in the second phase are this leaky lung syndrome, the acute respiratory distress syndrome, or this cytokine release syndrome, where basically the body is going into overdrive, trying to fight this thing and releasing these destructive proteins. What about reinfection and immunity? And I know I got to speed it up a bit. Not fully known, guys. Sorry, I don't have the answer. But the initial reports of reinfection where people were infected and then tested negative and then started testing positive again. A lot of criticism about that. Maybe this is just somebody who had persistent viral shedding. Maybe the test wasn't that good. So one thing that I can say is we're not seeing people get sick again and then coming back in for care. So that is not being seen. And most experts do feel immunity occurs. We just don't know how long it will last. And indeed, passive immunization or passive immunoglobulin from people who've recovered from COVID, taking their serum, combining it to get high amount of immunoglobulin in that, and then giving it to sick people is actually already approved by the FDA and has started in several areas. What about the test? Well, okay. So one thing, the test accuracy, I didn't put it down here, but the test accuracy of the PCR test varies. There's some of the labs where the test accuracy is only about 60% and other labs where it's closer to 95%. A lot of that is also the sample that's submitted because, you know, you got to have more virus to get a better specimen. So there's a lot of variability in the accuracy of the test. So I think we're trying to get that better. Abbott talked about this new test that can give point of testing results. So it's a little machine and you put the result, you know, the test in there and it tests either positive in 5 minutes or a negative test takes more like 10 to 15 minutes. No knowledge yet about the accuracy. This is very akin to the flu rapid test. It's an antigen test, then it's not a PCR test. So it is a molecular test, but so we don't know what the accuracy is going to be, but it's probably one of those where if it's a positive test, it's great. If it's a negative test, it may not completely rule it out. Lots of people have asked me about when are we going to get the blood test to tell if I've had it already. And if I've had it, then I can go out and I can go back to work and all of that. So there is literature out of China that they have developed an antibody test. People are working on that very, very aggressively. IgM, which is the first antibody that's raised by the body in response to any infection, has been detected fairly early into symptoms, so that's good. And then the IgG, which is the lasting antibody, pops up over a few more weeks. So all I can tell you is that that seems to be coming in the near future. I would like to say in the next few weeks. I think that's a reasonable projection. What about our vaccines? So Moderna, as you probably all know, started testing a vaccine candidate on March 16th. Their timeline, again, a year. I know that Fauci's talked about 18 months, but I think a lot of the companies have been trying to get it closer to a year. Johnson & Johnson, which partners with Janssen Pharmaceuticals, over the last 2 days indicated that they have identified a good vaccine candidate and 2 backups and plan to start phase 1 trials in September with results by December with vaccine production by January or February. So that's what they announced. We'll see what happens. And lots of other people are working on vaccines, as you can imagine. What about treatment? So chloroquine and hydroxychloroquine have gotten a lot of press. The slide here shows you how they work. I can tell you that we are doing that for our sick patients in the hospital. They get hydroxychloroquine over a 5-day course. It's very difficult to say whether it's working or not. I know that Michigan, I believe University of Michigan is going to publish a paper either today or tomorrow looking at benefit that they've been able to demonstrate, but they've used a slightly higher dose, so we'll probably all start doing that. But again, short course of therapy, not more than 7 days. Azithromycin seems to help through an anti-inflammatory effect. Where it was a very small trial, 30 patients from this guy in France, and he really showed some benefit with reduction of the amount of virus that was found when he tested patients. He didn't really look at clinical benefit, but he indicated in press releases that they did well. So, you know, a lot of question as to whether this is really the way to go, but because azithromycin is well tolerated and we know lots of good things about it, we are using it. So basically the patients get hydroxychloroquine and azithromycin for a 5-day course. Remdesivir is the only really effective, or what is thought to be an effective IV drug. It is in very, very short supply. We don't really know how well it works. It seems to have had some benefit in the people who it's been used on, but right now it's just not available, period. We're hoping within the next week or two that it'll be an expanded access, meaning, but this is only for people on ventilators who are very sick. What about Khaleja? Okay, so Khaleja has been looked at, and there have been 2 trials, one in patients who are very, very sick, one in patients who were not sick, and neither showed a benefit, but both trials had a lot of faults. So the sick trial, patients actually weren't even started on the medicine until they'd been on it they'd been sick for at least 13 days. So maybe it was just too little too late. And then the drug trial that looked at early disease was underpowered, and because this was actually in Wuhan and the epidemic had stopped and they didn't have enough people to enroll. So again, a lot of basically needs further trials, and those are ongoing. Other drugs, we're using statins to help protect the heart. There are a couple other drugs that are used for the cytokine activation syndrome. There's been a lot of question about the non-steroidals, ibuprofen. Basically, most of the big guys are saying there's not enough information to avoid this. You know, what can I say? Everybody comes in on them, so, you know, it's really hard to say if you should avoid them, but we are in the hospital trying to avoid the NSAIDs. And then finally, what about these ACE1 inhibitors and the ARBs? Again, data very unclear. Do they help? Do they hurt? And the American Heart Association is just saying, keep people on those drugs if they're on them. This is my last slide. What is the surge? Well, you know, you guys have all seen this, these types of graphs. So really what the surge is trying to address is based on our knowledge of the amount of people we think are infected in the community, and when we think these people who are in the community are going to require inpatient care and ventilators and all of that, you know, when are we going to see them get sick, and how many are we going to have to deal with? And that's the concept here. So the projection here, you know, the blue line, ventilators needed, Green line is ICU beds needed. Pink line, all the beds needed. I can tell you that the capacity that is projected when you hit the top of this surge, which is felt to be coming mid-April in the Chicago area, is not expected to be enough. And you can see up there at the top. So hopefully, we're going to dampen this out more than we expect, but that's what we mean by surge.